Ladies and gentlemen, good afternoon, and welcome to what we hope will be an edifying and enlightening discussion this afternoon of some very significant legislation that's been introduced by our friend and colleague Congressman Kennedy from Rhode Island and our friend and colleague Congressman Ramstad from Minnesota. The legislation bears the distinguished name of the late Senator Paul Wellstone in the state of Minnesota, who worked very hard for the issue of mental health parity. And that's going to be the issue that we have in front of the subcommittee this afternoon. There are 44 million Americans who are dealing with some kind of mental health issue in their lives. But only about 1/3 of those Americans are receiving care from a qualified, trained, prepared mental health professional for their issues. When asked why the other nearly 30 million did not receive care, an overwhelming majority of those individuals indicated that their problem was related either to insurance or the cost of insurance. 87% of those who are not receiving mental health services but who need them indicated that there were issues with their insurance policy which precluded them from getting that care. And 81% of those who did not receive care indicated that cost was a major consideration in their failure to access the care that they need. Now, 42 states have understood the problems with our present insurance system, and the problem, I think, succinctly can be summarized this way. It is presently acceptable under the law in many cases for an insurance policy to distinguish between a mental health issue and a physical health issue. So, for example, a person who injures her knee may have a $500 deductible toward dealing with a knee injury, and then after that, the insurance kicks in and pays a substantial part or all of what is yet to come. And typically, the number of visits the person would need to get their knee fit and trim is either unlimited or doesn't have much of a limitation on it. So as many trips to the surgeon as you need, as many trips to the physical therapist as you need, you get those trips until your knee is sound. On the other hand, if a person suffers from clinical depression and he or she needs the care of a psychiatrist, that person may find that there is a $5,000 deductible before the insurance policy begins to pay most or all of the cost of that psychiatric care. A person may also find that if they're fortunate enough to have the psychiatric care, there may be a very low limitation on the number of visits that he or she is permitted to make in a given year. So instead of as many visits as you need, you may find that you only get 3 or 4 or 5 of them, whether you are fully healed and prepared to deal with the rest of your life or not. I think these distinctions are arbitrary and unwise. And this is a view that has gained great currency around the country. 42 states have enacted some form of mental health law. Now, these are a mixed bag. Some of these state laws require specific mental health services. Others require a sort of parity between the care of physical and mental health issues. And still others will deal with requirements that insurers and employers must offer mental health coverage without any requirement that the coverage actually be provided. These are noble efforts by the states, and we're going to hear from a distinguished state insurance commissioner from Wisconsin later on the second panel about a very excellent effort in his state. I don't think they're sufficient for 3 very important reasons. The first important reason is that members of our society who are part of ERISA plans, that is, health insurance plans governed by the federal statute over which we have jurisdiction, are not affected by or protected by these state statutes. So the 52% of our workforce that works for an employer that's covered by an ERISA plan does not have the benefit of the state law statutes in these 42 states. Second, many of these statutes are limited in their reach. They don't solve all the problems that we set out to solve. And third, I believe that many of these statutes don't particularly fit together well with other federal efforts to deal with this problem. So it's my view that we do need a strong and well thought out federal standard to guarantee mental health parity. And I am a supporter of the efforts of Congressman Kennedy and Congressman Ramstad. I understand there's issues, and we want to hear those issues fully vetted today. But this effort by Congressman Kennedy and Congressman Ramstad has very broad bipartisan support. It is by no means the initiative of the majority party. It is the initiative of many like-minded members on both sides of the aisle from around the country. And I believe that it takes us in a direction where we can be successful. The final point that I want to make before I yield to my friend from Minnesota: very often when we try to expand insurance coverage, we get into a debate about whether the cost is worth it. And that's a debate we absolutely ought to have. We're going to hear this afternoon from an actuarial expert who will provide some compelling evidence that the results from the field show that the cost of extending true parity, which is what the Kennedy-Ramstad bill does, the cost of extending true parity is very low. The testimony will indicate that it's 0.6%, which is quite a low number, and I would point out that that is a gross number. That is a number of the projected increase in the insurance premium before one takes into account productivity gains, reductions in absenteeism, other physical health gains that would take place as a result of the implementation of such a policy. So I'm very pleased that we're here this afternoon. We're going to hear first from Congressman Kennedy. I would note for the record that Congressman Ramstad, of course, has been invited to appear to speak about his bill. His plane is evidently delayed because of bad weather conditions, but some people from Minnesota were able to soldier on and get here nevertheless. So I will at this point yield to my friend, the ranking member.
Thank you, Mr. Chairman. Some of us soldiered on last night, so we were ahead of the weather. I'm sorry that my Minnesota colleague, Mr. Ramstad, isn't here. I hope that he will be able to come sliding in from Dulles or wherever his plane safely landed. I want to thank you, Mr. Chairman, for holding this hearing to hear about, learn about, and discuss the Paul Wellstone Mental Health and Addiction Equity Act of 2007, named, I would point out, after the much admired and beloved late senator from Minnesota. I'm very pleased to see his son is here and will in fact be a witness in the second panel. And I'll just take this opportunity to say what a great panel it is, and we'll of course include Mr. Kennedy sitting there all alone waiting for Jim to show up. But the second panel, particularly distinguished witnesses from the minority and majority side, and of course we're honored to have the former First Lady with us here today. Legislation which provides greater parity between the health insurance coverage of mental and physical illness, I think has reached the point where most members of Congress agree we need to go. We are looking for ways to achieve that parity, and tremendous strides have been made, I think, in the last months and years in addressing the stigmas which sometimes have been attached to mental illness and its treatment. Clearly more needs to be done. However, there remain significant differences in how we should approach this. The chairman mentioned some of those, and we'll hear some of it today. Although it's well-intentioned, this bill, and I would say very well-intentioned, I have many concerns with the legislation as it is in front of us today. Initially, this bill constitutes an employer mandate. It seems ironic that at the time many of my colleagues in the majority professed to offer solutions to decrease the number of uninsured. It's the number one item, I believe, on their health care agenda. They're proposing issuing coverage mandates that appear to do the exact opposite by making coverage more costly and leading to less availability, and I don't think we want to do that. So we want to explore that here today. Secondly, the legislation does not preempt state laws that would provide greater consumer protections than those contained in the federal legislation. This means employers and plans could be subjected to multiple state laws, thus defeating the purpose of federal preemption of state laws and increasing plan complexity and cost. Other problems include the bill's broad definition of mental health or substance-related disorders and its failure to specifically protect a plan's ability to manage mental health benefits and control cost. Some of my colleagues in the Senate have introduced a mental health parity bill. Senate Bill 558 takes a little bit different approach. It's a product of lengthy bipartisan negotiations between patient advocates, mental health providers, business organizations, and insurers, and we'll receive some information about that bill today from one of our witnesses. Under the circumstances, regardless of whether you think the best answer is the Senate bill, the House bill, or no bill, today's testimony should prove helpful. I urge my colleagues to seriously consider the testimony provided today by all those, and certainly pay attention to the testimony from those talking about the Senate bill. And again, I want to thank the chairman for holding the hearing and for our distinguished witnesses for joining us today, and I look forward to the discussion.
Thank you. By unanimous consent, the statement of any other member who wishes to have an opening statement will be entered into the record, present or absent. We will begin with our first panel, and it's a pleasure to welcome, hopefully soon, both of our colleagues, but certainly one of our colleagues. Congressman Patrick J. Kennedy is serving his 7th term in Congress as representative of the 1st District of Rhode Island. Mr. Kennedy has received numerous awards for his advocacy on behalf of the mentally ill, including the Society for Neuroscience Public Service Award, the American Psychoanalytic Association President's Award, the American Psychiatric Association's Alliance Award, and the Depression and Bipolar Support Alliance Paul Wellstone Mental Health Award. It's a pleasure to serve with you, Patrick, as a colleague. We welcome you today, and we look forward to your statement.
Thank you, Chairman Andrews and Ranking Member Klein, and to my distinguished colleagues. Thank you all for the opportunity to invite me to testify today, and thank you for your commitment to ending insurance coverage discrimination against those with mental illness like myself. Let me begin by saying I suffer from the disease of alcoholism and addiction. I also suffer from bipolar disorder. I have, through the course of my life, had periods of time where I have had a mental obsession and physical compulsion to drink and use drugs in order to cope with a mental anguish that I have felt that today I no longer have to deal with through drinking and drugging, because I am a member of Congress and have access to the Federal Employees Health Benefit Plan, which has parity. And what is before you today is a bill that will extend the same treatment coverage that I have had as a member of Congress to the rest of the American people, so that as a member of Congress, the reason that I'm able to be here today as a fully productive citizen, as opposed to someone who's still out in the society drinking and drugging and unproductive, as opposed to someone who's at work living a full and productive life. The difference is that I have treatment, and the difference between me and some other American who doesn't have that treatment is that they don't have that access. And what we need to do today is have a parity in this country so that millions of Americans who are still out there suffering from that same disease that I have, that physical illness, that they can get the same coverage that I have and that we all have as members of Congress, and so that they can live productive lives. And if they live productive lives, they can be contributing members of society, as I hope that I am a contributing member of society. I know I could never have imagined myself when I first ran for office coming up here and saying I was an alcoholic and addict. I remember very clearly growing up in my family, whispering in my household as my mother suffered tremendously from this disease of alcoholism. It was a shame growing up to have this disease because of the scourge and stigma in this country that this disease has been. But I think that it's coming out of the shadows now, and that this country has finally come to a reckoning that this is no longer an issue of a moral failing. No one can convince me from looking at what this disease has done to my mother, or what this disease has done to millions of Americans like her that I have witnessed, let alone what I have witnessed in my own personal life, that people have chosen this life voluntarily. No one voluntarily chooses to live the kind of sordid, painful, destructive life that people who are alcoholics and addicts, or people who are depressed, or people who are suffering from schizophrenia or bipolar disorder, any number of mental illnesses, obsessive-compulsive disorder, any one of those illnesses, no one can convince me that that is a voluntary choice on their part. And essentially, that is what those who on the other side of this debate would have you believe. That this is a non-illness, that this is something that is non-physical, because if it were non-physical, then they could control it. And that is essentially what they would have you suppose, because if you were to believe that, then there wouldn't be any need for there to be insurance. But we know otherwise. The insurance system cannot hide the fact that brain science tells us otherwise. We have pictures. Modern science shows us these pictures that are clear as a bell, that the brain is a physical organ. And you cannot take a picture of the brain and look and say that the insurance companies can cover brain diseases like Parkinson's that affect the motor cortex and the basal ganglia and the sensory cortex and the thalamus, and then other brain diseases like depression, which affect the limbic cortex and the hypothalamus and the frontal cortex and the hippocampus, and they don't get covered, and yet they're 2 or 3 centimeters away. How can you justify 80% insurance coverage for one part of the brain and 20% insurance coverage for 2 centimeters away, or 0 insurance coverage for 2 centimeters away? How in the world can you explain that? Or you can say, well, no, sorry, as Mr. Klein said, we want to have the Senate language for the second part of the brain, but we want the current system of health insurance for the first part of the brain. It doesn't work. It's totally unjustifiable. Would you say the same with someone with cancer? Are you going to play with someone's life who has cancer that way? You take someone from your family who has a disease of cancer or diabetes, and you exchange that person's life and put in place mental illness and say that you're ready to bargain their life away, and answer that question, then I'll be happy to sit back and let you move on with your argument. But until you can honestly look me in the face and say that you're willing to put in place and substitute a person with cancer for that argument, or diabetes with that argument, or cardiovascular disease in that argument is specious, because otherwise it doesn't wash, frankly. This is a civil rights issue at its core. No one asked to have this disease. You're born with it. You have certain triggers through your environment that set it off. We're going to find all these things out in the years to come through genomics and personal health medicine, and we're going to have great revolutionary science help to solve many of these problems. But Mr. Chairman and Ranking Member Klein, if we don't move now, we're going to cost millions of Americans their lives. 34,000 Americans take their lives every year to suicide. That's twice the rate of homicide. Think of all the people that are killed by murder in this country, and think the fact that you multiply that 2 times, and that is how many people successfully take their own lives. That is a disgrace to this country. Think about the fact that the largest mental health institution in this country is our jail system. What an indictment on this country. And think about the fact that millions of Americans are not living up to their full potential, all because we have a discriminatory insurance system that continues to say that people are not living up to their full potential because we're not acknowledging this illness. I will say, but for the work of Paul Wellstone and Rosalind Carter, the former First Lady, who has been working on this issue for decades, and for Jim Ramstad, we would not have come as far as we have. And I just want to say, today I am standing on the shoulders of giants, and Jim Ramstad is with us in spirit. He has been absolutely no better champion for this cause than Jim Ramstad. And I am so honored to be his partner in this effort, and a fellow in the road to recovery. And I also want to say To David Wellstone, who's here on behalf of his father's legacy, what an honor it is to be joining him. He has done such a fantastic job in carrying on his dad's legacy. And to the former First Lady, she has dedicated her life to this issue. And the fact that she has done so with such compassion has been so moving to all of us. And I want to thank her personally for all of her great work on this issue. And for everybody in this today who's working on this issue, I want to thank them as well. And thank you, Mr. Chairman, for the time.
Thank you very much, Mr. Kennedy. I think the members of the panel have agreed that we want to get to the second panel of witnesses. If anyone would like to ask Mr. Kennedy a question, they're welcome. But Mr. Loebsack?
I just want to make a quick comment. I thank Patrick personally in the cloakroom after he was on Larry King for what he's been doing. And I have some personal experience with mental illness, especially with my mother. And I want to thank you again publicly for all you're doing. Thank you, Patrick.
Thank you. Patrick, what I would also like to add to that, most of us, well, all of us, are privileged to have the opportunity to serve our country as legislators, to do what we think is right for our country by virtue of the office we hold. It's a rare gift to be able to help because of your personal experience and your personal commitment. And you're certainly doing that today. We admire you for it, we respect you for it, and we thank you for being with us today. Thank you. We are going to move on to the second panel. If Mr. Ramstad is able to make it, we'll certainly have his testimony when he arrives. I would ask if the second panel could come forward. I'm going to begin reading their biographies as they come forward so that we can get started as they are settled. We are deeply honored to have with us the former First Lady of the United States, Ms. Rosalind Carter. In addition to her exemplary service as our nation's First Lady, Mrs. Carter created and chairs the Carter Center's Mental Health Task Force, an advisory board of experts, consumers, and advocates promoting positive change in the mental health field. Each year, Mrs. Carter hosts the Rosalind Carter Symposium on Mental Health Policy, bringing together leaders of the nation's mental health organizations to address critical issues. During the Carter administration, Mrs. Carter became active honorary chair of the President's Commission on Mental Health, which resulted in the passage of the Mental Health Systems Act of 1980. Welcome, Ms. Carter. It's a great privilege to have you with us today. Paul David Wellstone, Jr. is the son of the late Senator Paul Wellstone. He is the co-chair of the Wellstone Action Advisory Board and contributes to advocacy efforts on behalf of mental health and domestic violence. He is the co-founder of Wellstone Action, a national center for training and leadership development, as well as the founding partner of Family Place Home Builders, a business dedicated to building affordable housing. David graduated from Hamline University in 1987. It's great to have you with us, David. Amy Smith, welcome. Amy is the Vice President of Recovery Programs for the Mental Health America of Colorado and is the Director of Wellness and Education Coalition and Advocacy Network of Colorado, which acts as a consumer network and conducts the Colorado Leadership Academy, a week-long advocacy training for consumers. Ms. Smith has been with We Can since its inception in 2003. Welcome, Ms. Smith. It is great to have you with us. Neil Troutwine, did I pronounce your name correctly, Neil? Is the Vice President and Employee Benefits Policy Council for the National Retail Federation. He currently chairs the Coalition on Catastrophic and Chronic Healthcare Costs and co-chairs the Consumer-Directed Healthcare Conference. He received his B.A. in Political Science from the University of Louisville and his J.D. from the George Washington University. Welcome, Mr. Troutwine. John Breifogel is currently Executive Principal at the Groom Law Group, where he has worked since 1992, and John has been a frequent witness before our committee, both this subcommittee and the full committee. Previously, he served as Senior Legislative Officer at the Department of Labor and as Special Assistant to the Executive Director of the Pension Benefits Guarantee Corporation. He received his bachelor's from the University of Cincinnati, a master's in Public Affairs from Indiana University, and a J.D. from the George Mason University. John, welcome back. It's great to have you with us. Stephen Mellick has been a principal and consulting actuary with the Milliman since 1990. He has worked extensively in the behavioral health care field and specializes in healthcare product development, management, and financial analyses. He has chaired and served on various societies of actuaries and the American Academy of Actuaries task forces and working groups, most of which have been focused on behavioral healthcare issues. He has a BA in mathematics from the Illinois Institute of Technology. Welcome, Mr. Mellor. And finally, Sean Dilweg, pronounced correctly, is the Commissioner of Insurance for the state of Wisconsin. Prior to his appointment in 2007, Mr. Dilweg served as the Executive Assistant to the Secretary of the Wisconsin Department of Administration from 2003 to 2006. Previously, he worked as Director of Policy Analysis at SE Consulting Group, a major Madison consulting and lobbying firm, from 2000 to 2003. He holds a Master's in Public Administration from the University of Wisconsin and a Bachelor's in English from Lawrence University in Appleton. This is a very distinguished panel, and we're pleased that everyone gave us their time. For the record, the written statements that each of you has prepared will be submitted by unanimous consent to the hearing record and will be there in its entirety. We do ask that people try to summarize their oral statements in about 5 minutes. There is a light box in front of you. When the green light is on, you're in your 5-minute period. When the yellow light goes on, it means you have a minute left. And when the red light goes on, we would ask you to sum up and stop so we can get to questions. There is, however, a narrowly drawn exception for former First Ladies of the United States of America. And so if Mrs. Reagan or Mrs. Ford or Senator Clinton, I suppose she would also fit the exception, are welcome. Ms. Carter, please take as much time as you would need so you've graced us with your presence. We'd welcome you. We'd start with you.
Thank you for saying that. I was worried about my remarks. Mr. Chairman and members of the subcommittee, thank you for the opportunity to speak to you this afternoon about this legislation that is so important to so many people, millions in our country, parity in insurance. I have been working in the mental health field for, I don't like to say it, but because it ages me, but for over 35 years. That's a long time. When I began, no one understood the brain or how to treat mental illnesses. Today, everything has changed, everything except stigma, which still holds back progress in the field. But today, because of research and our new knowledge of the brain, mental illnesses can be diagnosed, they can be treated effectively, and the overwhelming majority of people living with these diseases can lead normal lives, being contributing citizens in our communities. Today, I join many individuals and hundreds of national organizations calling for an end to the fundamental stigmatizing inequity of providing far more limited insurance coverage for mental health care than for treatment of any other illnesses. And again, I join forces with my friend Betty Ford in urging prompt action on this important issue. Betty and I have lobbied many times for this legislation and for care. I have now a very good mental health program at the Carter Center. Annually, we bring together leaders to take action on a major mental health issue. We have focused many times on stigma and discrimination and the importance of ensuring adequate, equitable coverage for people with mental illnesses. To me, it is unconscionable in our country and morally unacceptable to treat 20%, at least 20% of our population, as though they were not worthy of care. We preach human rights and civil rights, and yet we let people suffer because of an illness they did not ask for and for which there is treatment. Then we pay the price for this folly in homelessness, lives lost, families torn apart, loss of productivity, the cost of treatment in our prisons and jails, and I could go on. I have always believed that if insurance covered mental illnesses, it would be all right to have them. This may be the reason stigma has remained so pervasive, because these illnesses are treated differently from other health conditions. All mental illnesses are potentially devastating. In my 35 years, I have seen so many advances in knowledge about the brain and improvements in treatments. I urge the subcommittee and sponsors to ensure coverage of all mental illnesses as defined by the DSM-IV. instead of treating some conditions as high priority over others. We had an intern at the Carter Center, for instance, this past spring, who suffered from obsessive-compulsive disorder and depression. And when she was in high school, she once spent 2 solid weeks in her house, not able to leave or to be with her friends. I'm happy to say that she received treatment, is a college graduate with Phi Beta Kappa honors, and just got a job here in Washington with the Ad Council. Without resources and support, she could still be sick and shut in her home, which is what happens to so many who do not get the help they need because they can't afford to pay for services. Our country loses all the many contributions of these wonderful people. Through the research of people like Howard Goldman and Richard Frank, we know that parity in insurance benefits for behavioral health care has no significant increase in total cost when coupled with management of care. We also know this from a number of enlightened companies such as AT&T, Delta Airlines, Eastman Kodak, General Motors, and IBM, and others, which have provided comprehensive coverage for their employees. Tom Johnson is one of my good friends. He's the former publisher of the Los Angeles Times and former CEO of CNN, and he has struggled with depression. He and 2 other prominent CEOs in the Atlanta community who have experienced depression have had an enormous impact on mental health benefits offered by businesses in the Atlanta area. I'm so pleased about that. In the last few years, there have been several major reports released. The first ever Surgeon General's report on mental health, President Bush's new Freedom Commission on Mental Health, and the Institute of Medicine included mental and substance use conditions in the series of reports on the quality of care of American health care. All of the reports reinforce the statement that effective treatments are available, but that most people who need them do not get them. The nation has learned a lot about the importance of mental health issues through Hurricane Katrina and the needs of our returning soldiers and National Guard troops. We support our troops in the field, and it is critical that we continue to support them when they come home. One other issue, many states have moved ahead with parity. These have been long-fought battles, with some states managing wonderful successes. It is so important that any federal legislation not preempt any of these gains. Well, we finally have mental health parity legislation in sight. This committee has worked long and hard to bring this legislation forward. It is an example of what can be accomplished with strong bipartisan support. When this legislation is passed, our citizens will be healthier and our nation will be stronger, more resilient, and more productive. On behalf of the millions of people affected by mental illness and substance use disorders, I applaud your efforts. The benefits to our nation will be enormous. Thank you.
Mrs. Carter, thank you very much for your statement and for your presence here today. Mr. Wellstone, welcome.
Thank you very much. Mr. Chairman and members of the subcommittee, I want to thank you for the opportunity to speak this afternoon on legislation that addresses an extremely critical health issue facing millions of Americans, parity for the treatment of mental illness and addiction. This legislation is very close to my heart, and I want to thank Congressman Kennedy and Congressman Ramstad, my good friend who is not here, for honoring my father's legacy and naming this bill. My brother and I founded Wellstone Action to carry on my father's work, and through the Wellstone Action organization, thousands of people are being trained each year to develop grassroots skills in organizing and leadership. But nothing represents my father's passion and commitment more than his work to end the discrimination against those who suffer from mental illness and addiction. Please accept the gratitude of my family and that of Wellstone Action for this tribute to my father. I also want to thank Mrs. Carter for her many years of leadership on this issue and many others related to mental illness. You and my father often worked together, and he was always, always very grateful for your support and leadership. I've been coming to Washington frequently to speak in support of this legislation, but my father started this work years ago. Many of you are familiar with the milestones in the long history of the fight for parity: the 1996 federal law, the 1999 executive order that gave federal employees mental health and addiction parity benefits, the many successes of grassroots advocates to strengthen state parity laws, the times that Congress came very close to passing the expansion of the federal law, and the endorsement by President Bush in 2002. For my father, these milestones were very, very personal. His dedication began when he witnessed the terrible conditions in psychiatric institutions where his own brother, my uncle, was hospitalized in the 1950s. These conditions and the eventual catastrophic financial toll endured by my grandparents inspired my father to do everything he could to make things right for those in similar circumstances. The legislation that my father and Senator Domenici passed in 1996 was groundbreaking, for it established in law an important first principle of parity, that those with mental illness should not be discriminated against in insurance coverage. But my father knew that that was not enough, and he was never satisfied with the compromises that were made at that time. That's why he immediately began the fight for a more comprehensive federal parity law, one that would include addiction parity and that would close the loopholes that the insurance industry had immediately started using to reduce benefits. His efforts over the years came close to success several times, including once during his last term in office. But despite promises then and promises made after he died, the federal parity law has not yet passed. This law is long overdue, and that's why we're here today. The bill has been negotiated for years, and important and fair compromises and protections are in place in the proposed House legislation that is the subject of this hearing today. It is time to move forward, for while we wait, people are suffering and dying from lack of care. The House bill has critically important provisions that will improve care, and I want to take just a couple minutes to mention them. The House legislation recognizes the essential role of scientific and medical knowledge in ensuring high-quality diagnosis and treatment by requiring the widely accepted DSM as the basis for coverage. Without this requirement, insurers and employers could decide, without the benefit of science or medical expertise, which mental illness or addiction diagnosis should be covered. I applaud the efforts of the House sponsors to stand firm in its effort to be clear about this requirement. It is important to close this potential loophole, one that could allow discrimination by diagnosis, something that has no place anywhere, but least of all in a parity bill. The House bill has important protections for state parity laws. In contrast to a current effort to preempt stronger state parity laws, my father advocated for the inclusion of protective language to prevent this preemption in bills he sponsored. In keeping with the principle of protecting state law, the House legislation includes important language, and I urge you to maintain those protections. We know from numerous reports, including one today, that the cost for parity is low, and we're going to hear that. Once cost is set aside as the reason for denial of parity, what is left is stigma and discrimination. Fortunately for our country, there are courageous people who fight against this discrimination, people like my friend Kitty Wellstone, who lost her daughter Anna to an eating disorder. Kitty's family faced this kind of discrimination but went on to help change the healthcare system in Minnesota and is now helping change the federal law. My father fought hard for those who had no voice, and he had a strong personal commitment to help those with mental illness and addiction. Congressional members honored his memory by promising to name the parity bill after my dad, and for that I'm grateful. But I do know the kind of man my father was and the kind of parity bill he would have wanted finally passed into law. The protections for patients that have been included in the House bill, such as protection for stronger state laws, full diagnosis coverage, and transparency of medical necessity, are essential to the kind of strong law that he fought for, and I urge you to include them in your final markup and passage. In the end, I am involved because this is the right thing to do. I want to do my part. This Congress has the opportunity to play a major role in history, and I urge you to do your part to finally enact a strong parity law. Thank you for your courage and your commitment to do the right thing, and know that I'll be there by your side with your efforts to pass this legislation. Thank you very much.
David, thank you very, very much for your statement. You know, your father was kind of shy and retiring. It was hard to get him worked up to speak for something, but I sure did hear him speak with great passion and commitment about this issue. We miss him very much, but I think we can honor the legacy of his life by moving forward. We're glad that you're here. Ms. Smith, I know you've had a long journey to get here today, and in more ways than one. We're very happy to have you with us, and welcome.
Thank you. Chairman Anders, Ranking Member Klein, and distinguished members of the committee, thank you very much, very, very much for this opportunity to tell my story. My name is Amy Smith, and I have lived my life with a serious psychiatric disorder. Most of my life was spent in a murky, confusing ocean of extreme emotions. I cycled in and out of mental hospitals, jail, and rather desperate attempts to lead a so-called life. Looking back on my childhood, I realized that I was already under the influence of mental illness. I remember a time when I was afraid to leave my bed in the morning to go to school because I was convinced there was an evil woman clad in flowing black robes and riding a black horse right outside my door that was going to get me. I did not relate to my peers, and I led a very lonely young life. As a young adult, my disorder, schizoaffective disorder, really blossomed. I had no idea what was happening to me as I became increasingly out of touch with reality and began a dark descent into profound depression. I quickly discovered that drugs and alcohol alleviated some of my symptoms. My solution to my difficulties was to stay high and drunk all the time from the moment I woke up in the morning until I fell asleep at night. I found it increasingly difficult to attend my college classes and consequently lost my grants, scholarships, and loans. I became a drug dealer to support myself, and after I was arrested, I became homeless for the first time, living in an abandoned trailer that had no doors or windows in the middle of a large field. As homeless shelters went, it was pretty luxurious. I was able to keep a small amount of possessions, and I didn't have to worry about other homeless people stealing my stuff or attacking me. One of the characteristics of severe mental illness is it's a very cyclical disorder, and I would experience brief windows of lucidity and clarity from time to time. When I was a young person, when that happened, I would experience momentous surges of hope, and thinking that all the darkness was lifted at last, I would craft extravagant plans for my life, not realizing that my schemes were grandiose and unachievable. As I became a more seasoned player in life, I would give myself over to my addictions in these times and just quit trying. The worst product of a severe mental illness, in my opinion, is a debilitating loneliness. Even as a very young child, I could not connect with the people around me, and it only got worse as I aged. I tried and tried to build a network of people around me to no avail. I remember one time I was attending a potluck and I had managed to wear some reasonable clothes, and I brought a dish to share. I was so proud of myself. I was in this crowded room filled with prospective friends, and I went to sit on the couch with a plate of food. As I was sitting down, I glanced down at the couch and saw that it was covered with hundreds of naked, squirming babies. I made a horrible sound and leapt up, my food flying. It was humiliating beyond belief, but fairly typical of my stabs at making friendships. I did, however, manage to have a child in an attempt to build a family around me. As life went on, my condition became worse and worse. I clearly looked like someone to avoid at all costs. I had dreams about what to wear, and if I didn't have a dream, I would wear the same outlandish outfits over and over again, sometimes for weeks at a time, so I had hygiene issues. I would either shuffle or stride up and down the street, depending on my mood, muttering to myself and occasionally verbally attacking passersby. My son, who turned out to be a person with psychiatric disorder himself, was living in mental hospitals and residential treatment centers. I could not keep him safe and lost partial custody of him to social services. My situation was pretty bleak. Finally, I had just had enough. I made a plan to kill both myself and my son. Fortunately, I told someone of my plan, and I was whisked away to a community mental health hospital. As I was on Medicaid, I entered into the Colorado community mental health system and immediately started receiving excellent care. I was determined to turn my life around. Working with my doctors and therapists, I started taking care of myself, sleeping appropriately, and eating decent food. It took a long time, but we found a cocktail of psychotropic medications that worked for me, alleviating my symptoms with very few side effects. I regained full custody of my son and started working. Today, I am a vice president at Mental Health America of Colorado. As happy as I am today, I'm heartbroken that 45 years of my life were lost. The jobs I managed to hold down had no mental health insurance and certainly no substance abuse care available. I had to go on welfare to get the care I needed. Things that people take for granted, like getting married, holding down a real job, driving a car, volunteering in the community, were beyond me most of my life. I was nothing but a drain on society. Today, I am a tax-paying citizen with private insurance. I am no longer ashamed to be the person who I am. We are very lucky in Colorado because we just passed a mental health and addiction parity bill. You have the same opportunity to do the same here, so people's lives are not wasted as mine was. Thank you.
Ms. Smith, thank you very, very much. As I said, you've had quite a journey to get here. And we're inspired by your testimony of great, profound admiration for you. We're very happy you're with us today. Thank you. Mr. Troutwine, thank you for being with us, and we look forward to your statement.
Thank you, Mr. Chairman and Ranking Member Klein and members of the committee. I appreciate the opportunity to appear before you today. By way of introduction, the National Retail Federation is the world's largest retail organization. We have a membership that comprises all different lines of distribution in all retail formats. I think there's a good chance you or your families know our members well. We are an industry with more than 1.6 million retail establishments across the country, more than 24 million employees, about 1 in 5 of every workers. As a labor-intensive industry, we're very concerned about good quality health care, keeping our workers healthy and productive and in place. As a labor-intensive industry that unfortunately endures wafer-thin profit margins from time to time, we're also well acquainted with the need to manage the collective cost of labor in as cost-effective a manner as is possible. Maintaining the balance between these two different imperatives is not the easiest jobs. In fact, sometimes it's darn near impossible. Mandated coverage for benefits tends to disrupt that balance and makes it more difficult for our members to provide jobs and benefits both. So we have tended to oppose benefit mandates. Indeed, we oppose the legislation before you today, H.R. 1424. But our opposition to this bill doesn't mean we oppose all mental health parity legislation. In fact, we are supporters of the Senate bill, specifically the manager's amendment to S-588, the Bipartisan Mental Health Parity Act. We think the Senate bill would make the better law by far and would support that law being enacted and support that bill being enacted into law. We feel that the House bill is similar in many respects to the previous bills that we've opposed on both the House and the Senate side. In some ways, it's a little bit worse than the bills that we've worked on in the past. We oppose H.R. 1424 primarily because of its broad benefit mandate, its lack of protection for medical management, provisions allowing the states to enact more extensive provisions, and provisions mandating out-of-network coverage. In the interest of time, I'm going to concentrate on the first issue and then discuss why I think the collaborative Senate process has developed a better bill and one that has gotten us working arm in arm with the mental health community. Again, as noted, it's fairly confusing, as the House bill doesn't specifically address the DSM, but instead links to the most widely subscribed Federal Employees Health Benefit Plan program. That in turn references the DSM, so it's really a circular process. Although advocates of the House bill tend to point to the fact that the fee plans have been able to deal with the cost of coverage without great cost impact, I would point out that fee plans enjoy the ability to medically manage that benefit and do so fairly aggressively. And that's why we're particularly troubled by the lack of a specific protection for medical management in the House bill. In addition, I would note that no other profession has had its professional manual enshrined into benefit coverage in the way that the House bill would, by indirection, enshrine the DSM. Typically, insurance plans tend to work the opposite direction by exclusion of specific conditions rather than inclusion of conditions. So it's really out of place in benefit coverage today. We think the better approach has been taken by the Senate because it allows plans to define the scope of coverage. It also allows the states to continue to define coverage for state-regulated insurance plans. This debate has been long and fierce. It's lasted through many, many years. I worked with Mr. Wellstone's father in the past on this issue. Certainly the rhetoric has been tough. I've contributed my share of that. It's really a shame because it's obscured what has been really a shared purpose to help people get the kind of coverage that they need in the process. That shared objective has really encouraged a dialogue between the different sides and with the Senate sponsors. I would particularly like to give thanks to Senator Kennedy, Senator Domenici, and Senator Anzi for being good negotiating partners and fair advocates for both sides of this debate. The balanced Senate compromise I've highlighted through this testimony has been the product of those negotiations. What's particularly interesting, and to try to sum up, has been that it's not only typical allies like the American Benefits Council, like the Chamber, like the NAM, but we're also working with the National Alliance of Mental Illness, the American Psychiatric and Psychological Associations, the hospitals, and many others. And you'll find a copy of our joint letter together at the end of my written testimony. Again, I appreciate the opportunity to appear before you today and hope we can continue to make progress on this, and hopefully we'd like to work with you to see the Senate bill enacted. Thank you, Mr. Chairman.
Mr. Trautwein, thank you for your very thoughtful and comprehensive statement. We appreciate it. And Mr. Breyfogle, welcome back to the committee. We're happy to have you with us.
Thank you, Mr. Chairman, Mr. Klein, members of the committee. It's really an honor to be on this panel with such a distinguished group, people with a long history in the subject. It's an important subject. It's something that employers view as important. The American Benefits Council represents predominantly large employers and people who provide services to employer plans. The plans that the American Benefits Council represents cover over 100 million Americans. The vast majority of employers, and virtually all large employers, cover mental health in their health plans. At the outset, I'd like to say that we've been privileged to be part of the same negotiation process in the Senate, and the Senate bill that is being supported by this coalition is a substantial expansion of the parity requirements. Current law only requires parity for annual limits and lifetime limits. We are supporting a bill that would extend parity requirements to virtually all treatment limits and financial requirements. It's also a bill that would expand the definition of mental health to include substance abuse. It's also a bill that would substantially narrow the cost exception. So under any measure against current law, it is a large expansion. It's a large expansion against many state laws. Very few state laws measure up to this kind of parity rule. There are some basic principles, though, that the Council has in evaluating this legislation. They're basically the following. We need to have some flexibility in how we design our health plans in terms of what's covered and what's not. We need to have the flexibility to manage health benefits so that if we're going to cover something, we can attempt to control the costs and maintain quality. We would like to have uniform federal rules where there's a comprehensive federal standard, like the parity rule would be in the Senate, while protecting the roles of the states in the insurance world where they want to mandate mental health benefits and the like. Another basic principle is we want to avoid expansions of new special purpose remedies, new lawsuits, new damages provisions. When we look at the Senate bill, it basically meets our requirements. It's not everything that the employer community wants. It goes, frankly, much farther than the employer community has been over time, and I think under any measure would be a major victory for mental health advocates and would benefit from the consensus approach. The thing that the Senate bill doesn't do that we appreciate is that it doesn't have effectively a benefit mandate, because it leaves it up to employers to define what their health plans cover, so it doesn't follow the DSM-IV rule. I read a study. I think only 12 of the states that have parity rules follow DSM-IV, so it's not as widely as accepted as you might think. Senate bill makes clear that medical management principles are preserved, at least for self-insured plans. It does have a narrow and targeted preemption rule, but just for the parity requirements. So there are special rules in the Senate that protect state authority, traditional state insurance authority, in many, many respects. I think I'd like to mention there was a pretty comprehensive analysis of the state Senate's preemption rules done by Professor Rosenbaum of GW's School of Public Health, which is I think reflective of the same analysis that we're providing. And she and I think we concluded that the following, that mental health mandates are clearly preserved under the Senate bill. Where there are parity requirements coupled with mandates, the mandates would be preserved. Individual and small group market parity laws are preserved from preemption. State authority to define mental health benefits for insured plans are preempted. State laws that would mandate insurers offer out-of-network coverage for mental health would be preempted. So state laws that limit the ability of insurers to manage mental health benefits would not be preempted. So there's this whole body of state insurance law that's not preempted under the Senate bill. So in terms of the House bill, I think our concerns are pretty much mirror image points. That the House bill would limit the ability of employers to define what benefits are covered by reference to the DSM-IV through the methodology that Neil pointed out. It also has no specific protection for medical management. It actually shares the same treatment and financial limits rules. It shares the same cost exemption, so it has many of the same basic rules in it. There's another major concern we have with the House bill, which is that there's a provision in it that specifically accepts from preemption remedies, greater consumer protections, benefits, methods of access to benefits, rights, or remedies. That is very different than current law. That is not the sort of floor-ceiling HIPAA rule for the technicians in the audience. The House bill is amending an ERISA provision that already preserves state insurance laws, but this provision would arguably allow for state lawsuits and remedies just with respect to mental health benefits, and that is very different than the current rule under ERISA, where ERISA provides the exclusive set of remedies as a federal statute. Thank you for your time. I look forward to the questions.
Thank you very much, Mr. Breyfogle. As usual, very well prepared. Mr. Mellick, welcome to the committee. We look forward to hearing your statement.
Good afternoon, Chairman Andrews and members of the Subcommittee on Health, Employment, Labor, and Pensions. It is my pleasure and honor to testify before you on the Paul Wellstone Mental Health and Addiction Equity Act of 2007. My name is Steve Mellick, and I am a fellow of the Society of Actuaries and member of the American Academy of Actuaries. I'm a healthcare actuary with Milliman, which is a leading actuarial consulting firm that consults to virtually all health insurers and managed care plans in the U.S. and many employers. I've been with Milliman for 17 years and have specialized in actuarial work related to behavioral health care. Our report contains the findings of the Milliman authors. Please note that Milliman does not endorse legislation. My work with Parity dates back to the analysis of the Health Insurance Reform Act of 1995. I've personally helped health insurers, providers, employers, managed behavioral health care organizations, and state governments price behavioral health benefits, including legislation in Nebraska and Washington state within the last year. Milliman was commissioned by Capital Decisions, Inc. on behalf of several behavioral provider organizations. Our full report contains important details about our findings, sources, and methodology. From an actuarial standpoint, Parity will bring the benefit limits and cost sharing for behavioral health care in line with medical benefits. For example, a benefit plan might have a $10 copay for an office visit for a medical condition, but a $25 copay for a therapy visit to a psychologist. In addition, a benefit plan might limit behavioral therapy to 20 visits per year, but have no physician visit limits for medical conditions. Obviously, that can increase costs for the insurer or employer, and it will decrease the amount the patient pays out of pocket. Our estimates show that the cost increase is modest relative to total healthcare costs and to the ongoing annual cost increases of health benefits. We estimate this legislation would increase per capita health insurance premiums of typical health plans in 2008 by an average of 0.6%, or $2.40 per member per month in our baseline scenario. In that scenario, we assume that employers and health plans will take no steps to compensate for the added cost, such as increasing cost sharing or increasing utilization management. Thus, our estimate is conservative, meaning it's on the high side. Employers and insurers commonly try to compensate for increased costs by reducing benefits or increasing employee premium contributions. The CBO, in its cost analysis of Senate Bill 558, considered that employer responses will remove about 60% of the cost increase. Applying this CBO figure to our baseline scenario increase of 0.6% reduces the net cost increase to about 0.2%. Another response of employers and insurers to increase costs is to increase the intensity of utilization management. The legislation does not appear to prevent the use of utilization management, or UM. We developed another scenario, our increased UM scenario, where payers would tighten their behavioral health care utilization management. In this scenario, our cost estimates result in an aggregate premium increase of less than 0.1% or 3 cents per member per month. As members of the subcommittee are well aware, there is enormous variation in the health system, and the increase for any specific insurance plan will vary with many factors. While we can construct a set of circumstances where the cost increase for a specific plan could be 1 to 2% or more, we believe such plans cover a small portion of the people with group health coverage, probably less than 5%. Increasing benefits for behavioral health care services may result in reductions in other health care and employer costs. This is because better behavioral health care can improve a person's medical conditions. It may also lead to an increase in the use of psychotropic drugs. We did not consider these effects in our report. We assumed coverage consistent with DSM-IV, but we did not include treatment for tobacco use, obesity, or the side effects of medication. We provide some information and references regarding the well-established evidence base for diagnosis and treatment of mental and substance-related disorders, which is on par with that for diagnosis and treatment of medical and surgical conditions. We also summarize how this evidence should be used for medical necessity determinations by payers in the utilization management process. We also present summary information from Thompson Healthcare's work for SAMHSA. It shows that spending trend increase for mental health and substance abuse-related services was less than that for total healthcare spending between 1993 and 2003. Future growth in behavioral spending is also projected to lag other healthcare spending, partly because there is less new technology expected for behavioral than for medical care. Another trend we report is that the private insurance portion of national mental health spending increased from 21% in 1986 to 24% in 2006, while substance abuse disorder spending decreased from 30% to 9%. Thank you again for the opportunity to present our report today.
Mr. Milk, thank you very much, and as I say, your entire statement has been entered into the record. Commissioner Dilweg, welcome to the committee. All the way from Wisconsin, we're happy to have you.
Thank you, Chairman Andrews, Ranking Member Klein, and members of the committee. My name is Sean Dilweg. I am the Insurance Commissioner from the state of Wisconsin. Thank you for inviting me to testify this afternoon on the Paul Wellstone Mental Health and Addiction Equity Act of 2007. Today, I will speak to the importance of parity legislation and highlight the importance of H.R. 1424 in addressing unequal coverage limitations on mental health services. In addition, I will express my concern with preemption language included in the amended Senate Mental Health Parity Bill, which leaves Wisconsin's mental health mandate and laws in other states vulnerable to court interpretation. There are currently 46 states with laws requiring some level of mental health coverage and 27 states with full parity laws. I have had discussions with other state commissioners who are strongly concerned with the Senate language. Individuals diagnosed with a mental illness are too often limited in their ability to access treatment due to insufficient insurance coverage. Such treatment limitations force this population to look to their own finances or public programs as means to cover expenses. In the worst cases, people forgo services altogether, given the debilitating nature of many mental illnesses. Individuals find they cannot maintain employment, health conditions related to mental health illness go untreated, and people generally find themselves unable to maintain the quality of life most of us enjoy. The House bill will greatly improve access to mental health services by ensuring individuals the same level of insurance coverage for their mental health needs as would be available for their treatment of other medical conditions. In Wisconsin, group health insurers providing coverage for inpatient hospital treatment, outpatient treatment, or both must also provide coverage for mental health and alcohol and other drug abuse services. This means insurance companies selling health insurance coverage to employers in Wisconsin must include coverage for mental health-related care. State law requires a minimum of $7,000 in coverage be provided for these services, but also allows plans to limit benefits to the statutory amount. These coverage requirements do not go far, especially for those who have a severe mental illness or dual diagnosis. This has been in place for 30 years. I have seen democratically controlled Senate, House, and Governor in our body, and also Republican-controlled, and we have never been able to change this to full parity. I welcome the fact that you are pursuing full parity under the preempted ERISA plans. The gaps in coverage across the nation with regard to mental health services are vast. There are also disparities between what group health insurers and the self-insured are required to pay within states across the nation. Some employers have been known to move to a self-insured plan specifically to avoid the state mandates. Once again, I welcome the federal mental health parity law and look forward to action on this bill. I also commend Representatives Kennedy and Ramstad in their efforts to improve coverage of mental health benefits in private health insurance while ensuring that federal standards serve as a floor, not a ceiling. This is consistent with the preemption language in the Health Insurance Portability and Accountability Act of 1996. HIPAA's portability and access provisions affecting private health coverage has been a model for how federal and state health coverage reforms can work together, with states having the flexibility to supplement federal standards to better protect consumers when necessary. In moving forward towards equity and coverage for mental health services, it is important to maintain the recognition that state policymakers may determine it necessary to have a stronger set of standards to ensure the protection of patients in state-regulated health insurance policies. Under the Senate version, it would be very problematic for Wisconsin and other states if the House were to move in the direction of the Senate with regard to preemption. Senate version preempts any state mental health parity standard or requirement which differs from the mental health parity standards required in the bill. Wisconsin and other states are struggling to predict how the preemption language may impact our current parity laws. Concerns have been expressed on the impact to mental health mandates in states including Washington, Vermont, Oregon, Connecticut, I just spoke with California this morning, Montana, Maryland, and Nevada. In states such as Wisconsin, California, Maryland, and Montana, where the mental health parity laws apply generally to health insurance coverage, and there is no distinction between small and large group coverage, it is questionable whether courts will uphold these laws as they apply to individual and small group policies if challenged under ERISA. As a result, the legislative intent in the bill to save state, individual, and small group coverage from preemption may not be accomplished. Washington and Connecticut have a mandated benefit and require parity with medical coverage. If these mandated benefits are preempted by unclear language of the manager's amendment, carriers would not be required to provide mental health benefits, leaving consumers at risk of losing coverage they currently rely on. In conclusion, as the insurance commissioner charged with protecting consumers, I have a responsibility to bring to light issues that may put consumers at risk. The intent of the House and Senate bill is laudable. However, the Senate preemption language opens the door for an all-or-nothing situation in Wisconsin and other states with similar mental health mandates. I have raised several preemption questions. There are others that may come to light as other states more carefully review the proposed language. These could be open to interpretation and based on new ERISA-related litigation that will come at a high price tag for people who may lose benefits while waiting years for courts to determine if state laws are preempted. The preemption language included in the House is clear and will preserve and strengthen Wisconsin and other states' mental health mandates, as well as many mental health parity laws across the nation. Thank you again for this opportunity to talk.
Well, thank you, Commissioner, and we thank all the witnesses for giving us an excellent basis for our discussion as a committee. I would ask unanimous consent that 2 letters dealing with the issue of the scope of preemption in the Senate bill be entered into the record. The first is from Mila Kaufman, Associate Research Professor at Georgetown University, and the other is a letter from Gregory Heller. That without objection, that be entered into the record. Again, I'd like to thank each of the witnesses for very edifying testimony. And Mr. Troutwan, I wanted to come to you for a moment. You had said that one of the effective cost control strategies for insurers and employers who offer a mental health benefit is medical management. When you say medical management, what do you mean?
This is the process of making sure the appropriate care is directed to the individual. So it's a question of matching the care to the person.
So, for example, an insurer would determine whether the level of care, whether a psychiatrist would be appropriate or a therapist or some other form of care provider. Is that correct?
It's basically a check on not only on utilization, but you want to make sure that the care is effective, that is, helping the particular individual.
And in your testimony on page 2, you say that you were troubled by the lack of specific protection for medical management of benefits in the bill before us. Where in the bill that's before the committee is there any language that would prohibit the kind of medical management that you're making reference to?
That's precisely what troubles us. The previous House and Senate bills had specific provisions. In fact, former members, Mrs. Rockema in the past, very much emphasized the protections for medical management as a means of keeping the overall cost of the bills down. So this lack of specific provision.
Yeah, I understand that there's not a specific provision saying that insurers can do this, but where is there language that says they can't?
The answer is there is no line, but there's also the lack of a positive protection leads us to believe that there could be inroads on our ability to do that.
So if I understand your argument, it's that in the matter of an insurance contract that's governed by ERISA, if a specific practice isn't authorized by the statute, the insurer can't do it? Is that your position?
I think our primary concern is at the state level that the states might...
Well, of course, we're talking about this bill, though, what's in this bill. So is it your position that if ERISA as amended would not specifically authorize an insurer or an employer to do something, they can't do it? Is that your position?
No, sir.
Well, then why would we be concerned then about this bill? It seems to me that the bill's silence about the availability of medical management techniques for insurers and employers means they could utilize them, doesn't it?
I think to an extent it does, but we would feel better and more secure if we had that provision in there.
Mr. Mellick, in your testimony, you talked about medical management provisions, and I want to make sure I understand this correctly. In your conservative estimate, meaning I guess in this case that medical management tools either couldn't be used or weren't used as aggressively as they could be, it's your conclusion, isn't it, that the average increase is 0.6% in outlays? Is that correct?
That's correct. If there is no response to increase utilization management or the employers didn't take additional action to reduce their costs.
Could you tell us again what your conclusion was if, under your so-called increased scenario, which I take it means more profound use of the tools that Mr. Troutwine just talked about, what was your cost increase projection if that happened?
Well, it's as close to zero as you can get. It's 3 cents per member per month.
3 cents per member per month. And let me also ask you, I think I understood that you said that your calculations were gross cost calculations, meaning that you did not take into your analysis reductions in absenteeism, increases in productivity, decreases in physical and surgical health outlays. Is that correct?
That's correct.
So it's plausible, isn't it, that if one were to take those into consideration, that you could make a strong argument that the payer, the insurer or the employer, actually has a net benefit from implementation of mental health parity. Is that not correct?
That's correct.
Ms. Carter, has that been your experience? That you mentioned Mr. Johnson from CNN and others. Has that been your experience over the years that employers who have voluntarily adopted parity programs have seen a business benefit? I'm sorry, Ms. Carter. Could you put your microphone on?
I said I don't understand what he's talking about, because what we've seen in the mental health, we in the mental health community have been watching companies for years who have voluntarily had parity insurance for their employees. And what we have seen happen is that over the first few years, insurance might go up just a very little bit. But over 3 or 4 or 5 years, the total cost of health care for the company comes down, because people who go for physical health, I don't like to make a distinction because I don't think there should be a distinction, but people who go for physical health who are depressed or suffer from some mental illnesses keep going and don't realize it, keep going to the doctor and going to the doctor, and the health costs are more than when they receive mental health care. Then they don't go to their physical health doctor.
So, Mrs. Carter,
so it's over a period of time, in all the ones that we have studied, the health care costs, the overall health care costs came down.
this, Mrs. Carter, would be the person who gets treatment for clinical depression and therefore doesn't suffer significant weight loss and a stroke or a heart attack or something that comes with that then, right? That's what we're really talking about.
Yes.
Somebody has that kind
Yes.
of
And well, people who are depressed don't feel good. They don't know what's the matter. They have stomach aches and all kinds of aches and pains and just keep going to the doctor for care.
Very well. I understand that our friend and colleague, Mr. Ramstead, has arrived. Is that right, Jim? Are you here? Jim, please come forward, and with Mr. Klein's consent, I'm going to recognize Mr. Ramstead for a statement at this time and then go to Mr. Klein for questions, if that's okay. Jim, there's a... Okay.
Excuse me.
Without objection. There is a seat for you, Jim, at the end of the table there. We're glad to see you arrive safely. We welcome you, and thank you for the great work you've done on this issue.
And distinguished committee members, friends all, thank you very much for your indulgence and for allowing me to testify out of order today. What's normally a 2-hour flight from Minneapolis turned into a 5-hour ordeal by way of Dulles, so thank you very, very much. Some of you know on July 31st, 1981, I woke up from my last alcoholic blackout under arrest for a variety of offenses in Sioux Falls, South Dakota, the city jail. And I'm alive and sober today only because of the access I had to treatment, along with the grace of God and the support and fellowship of other recovering people over the last 25 years, 11 months. But too many people don't have the access to treatment that Patrick Kennedy and I had. I believe it's a national disgrace that 270,000 Americans last year were denied addiction treatment, according to SAMHSA. I think it's a national tragedy that 150,000 of our fellow Americans died last year as a direct result of chemical addiction. 34,000 Americans committed suicide as a direct result of their untreated depression. And I know there are some people on this committee concerned about cost. Let's look at the cost. It's a national crisis that untreated addiction and mental illness cost our economy over $550 billion last year. That's according to respected actuarial firms that have done those studies. And of course, the costs that can't be measured, I'm sure you've heard today from witness after witness, it can't be measured in dollars and cents. The human suffering, the broken families, the shattered dreams, the ruined careers, the destroyed lives, and on and on and on. It's time to end the discrimination against people suffering the ravages of chemical addiction and mental illness. It's time to end the higher co-payments, the deductibles, the out-of-pocket limitations, costs that are higher than people who undergo treatment for other diseases pay. These are discriminatory barriers to treatment that don't exist for other diseases. And if you accept the premise of the American Medical Association, 1956, that mental illness is a disease, that addiction is a disease, then you can't justify this discrimination vis-a-vis other diseases, this discrimination in treatment. And that's why we've worked so hard on the Paul Wellstone Mental Health and Addiction Equity Act. So many of us, I'm sure Patrick Kennedy, our colleague from Rhode Island, explained the 14 field hearings that we had across this land. People desperate for greater access to treatment, people suffering the ravages of these diseases, people who want the discrimination ended. And speaking of cost, we had at these field hearings CEO after CEO who have either on their own as self-insured or through their health plans already provided treatment equity for their employees. CEO after CEO after CEO testify they are saving dollars. They are saving hundreds of thousands of dollars, small, medium, and large-sized companies. We had 6 insurance plan CEOs testify in support of this legislation. Why? Because they've seen all the empirical data in the world that shows parity doesn't cost, it saves dollars. So I urge this respected committee, all friends, all of you, that you mark up this important life-saving bill. with me, this isn't just another public policy issue. This truly is a matter of life and death, because I've seen my two uncles die from untreated alcoholism. I've seen others suffer immeasurably from their mental illness and chemical addiction. I've seen families torn apart by the ravages of their child's addiction. And we can address this problem as a nation by passing this bill. It won't raise premiums. This is according to Milliman and Robertson, again addressing my friend's concerns about cost. Milliman and Robertson, the highly respected actuarial firm who doesn't have a political axe to grind, said in their study that for the price of a cheap cup of coffee per month, 16 million people in health plans can receive treatment for their mental illness or chemical addiction. Again, I'll be glad to furnish the actuarial studies to anybody who argues that this is going to be a costly mandate. First of all, it's neither. It's not a mandate, and it's going to save literally billions of dollars. Let me conclude, Mr. Chairman, and again, you've been very generous, and I appreciate the chance to testify here today. Let me conclude by saying as strongly as I can, it's time to end the discrimination against people who need treatment for their mental illness and addiction. Thank you, Mr. Chairman, members of the committee.
Well, Mr. Remstead, thank you for being here and being with us, and we celebrate your continuing personal victory as well as your commitment to this cause very, very much.
By the way, Mr. Chairman, one addendum I'd just like to add. We appreciate also the support of the President of the United States, who endorsed the parity legislation in 2002 in a speech in Albuquerque, New Mexico, when he was with the Senate chief sponsor, Senator Domenici. So we're anxious to get the bill down to him to sign.
As we said, we believe we have a lot of bipartisan support for this legislation. I'm going to turn now to my friend from Minnesota, Mr. Klein, for his questions.
Thank you, Mr. Chairman, and welcome, Jim. I will congratulate myself again for having chosen to come back last night. I don't know what moved me, but so I know what that means when a 2-hour flight turns into a multi-hour ordeal. Glad to see you. I'm glad you made it. Glad you're safe. A couple of comments and questions. I think many of us are eager to move forward with some parity legislation. And part of what we're talking about today is, and we're trying to learn about, are the differences between the Senate bill, co-sponsored by Senator Kennedy and Senator Domenici, and the bill that the President was talking about. What's in that bill versus what's in the House bill that's sponsored by our colleagues, Mr. Ramstead and Mr. Kennedy. And by the way, I, of course, always appreciate the passion that, Jim, that you bring to this, and our colleague Patrick as well. And so I've got some questions, probably not for you, Jim, but for some of the other members of our panel. And by the way, Mr. Chairman, I'd like a unanimous consent to submit this letter for the record from George Washington University. Medical management has been an issue discussed back and forth here, and the chairman correctly asked, well, if it's not explicitly excluded, can't we assume that it's there? And I guess I would ask the question, what would be the harm in making sure that the language is put in there to explicitly allow it? Can you address that, Mr. Troutwine, and why that would make you feel better and what the concerns are?
Well, again, in the administration of benefits, there's always a tug-of-war about who can do what, when, and where, and not only the tug-of-war and preemption between what the federal government can do, what the states can do, but in terms of regulation, what plans can do and what the restrictions are. So I think we would be much more comfortable if that language was there, as it has been in past bills.
Okay, thank you. And I think, in fact, when we were talking about the 0.6, 0.3, 0.2, at least initially, I think, Mr. Mellick, didn't you make an assumption that there was medical management, and then you looked at different levels if you didn't have it? Is that correct?
Yeah, in our baseline scenario, we had a 0.0, excuse me.
Take your time.
A 0.6% increase that had an underlying.
Let me interrupt. An underlying assumption that there was medical management at sort of
That's
current
right,
levels.
compared to what is currently commonly in place in managed care plans.
Okay. And so you would, in order to sort of solidify your analysis, it would be clearer and easier for you if you had explicit language allowing medical management. Is that correct?
I think that's correct, although de facto in healthcare today it's used.
Okay, thank you very much. Now, we were in a discussion earlier when talking about the House bill, and I think, John, you brought it up in your testimony about new remedies that might be available and litigation. What have you got? Can you expand on that, what those costs might be and what those remedies might be, what the impact would be?
Right. And before I do on the medical management point, there are a couple of provisions in the House bill that I do think warrant the clarification we're asking for. First of all, the House bill imposes a broad requirement that there be no differences in treatment limitations. And treatment limitations is fairly broadly defined. So if you had different UR tools that were being applied to medical benefits versus mental health benefits, you might see somebody arguing that there was non-parity in that regard. So there's the issue there. The other provision in the House bill is actually the one that's the remedies provision, which basically says nothing, to paraphrase the medical management point, nothing in the state law should be construed to preempt any state law that provides greater methods, greater consumer protections methods of access to benefits, et cetera. So I don't know what methods of access to benefits means, but if a state law were to regulate UR, that's a method or imposition on accessing benefits, arguably. So I think there's some unclarity there that relates to medical management.
So it's explicit language.
There are a couple of provisions that I do think, and that provision might be read to just apply to insured plans, but it might be read more broadly, and the treatment limits rule clearly applies to self-insured and insured plans. The second point on medical management is the law does not preempt state insurance laws as to insured plans. So there are states that do bar medical management for mental health and limit it. So already there's a built-in preservation of anti-medical management laws in the insured market in the House bill. We didn't get everything we wanted in the Senate bill, which has essentially that same framework. But those are the reasons why we want the clarity in this bill. As to the remedies point that you asked, basically ERISA provides the exclusive set of rules for litigating claims under ERISA plans. It's in federal court. It has certain remedies. State laws that provide punitive damages, compensatory damages are completely preempted. That's all very settled. There's a special rule that's being added to just for mental health benefits provisions that saves state remedies. I mean, remedies is a pretty precise term, legally speaking, and so I think if you have a dispute over whether a parity law is being followed and you're in an insured plan, you have a darn good argument under the House bill that you can sue for whatever state law remedies are available. Punitive damages, compensatory damages, et cetera.
Okay, thank you. And I thank the chairman for letting me go past the time. Go back.
Thank you very much, Mr. Klein. Mr. Kildee is recognized for 5 minutes.
Thank you, Mr. Chairman. First of all, thank all of you. Mrs. Carter, I arrived in Washington with you and your husband in 1976. You were very kind, by the way, you and your husband, to my children who were 4, 5, and 6 at that time. They used to play in the treehouse with Amy in the backyard of the White House. As a matter of fact, my 4-year-old left for Baghdad last night again, and it's good to have you here, and thank you for all you've done in this field. Let me ask you this. We know of the inequality between mental and physical health treatment, and there's still some amongst us who have either a medieval or superstitious attitude towards mental health, and that attitude has changed a great deal in the 30 years that I've been in Congress. But that lack of understanding is found among people in government and people in business. Is that lack of understanding greater in business or greater in government, or have attitudes changed and it's now more of a false concern for cost for mental health?
Well, first, congratulations on being able to stay in Washington.
Thank you.
I think attitudes are changing a little bit. I think for the first time since I've been involved, the stigma is beginning to lift. We still have a long way to go, but I think it is beginning to lift. I think that Katrina and soldiers coming home, National Guards people coming home, have helped people to see that mental illnesses are real and that people need help. The stigma goes back to when, actually, before I first started, of course, for generations, but when I first started, people were being moved out of the big central hospitals into communities with no services available, and nobody knew how to treat mental illnesses. There was no science about no knowledge about the brain, and that's all changed. And so many people still have that same attitude about mental illnesses that was prevalent back when I first began. But today, mental illnesses can be diagnosed and treated, and the overwhelming majority can lead normal lives, living at school, living at home, going to school, working. And so to me, it's just a tragedy that we don't help people. We relegate them to a lower standard because of the illness. I hope government is changing, because I really want to have this Parity bill passed. And I do think businesses, from what I've seen over the years, businesses are beginning to come around. I don't think it's just because Tom Johnson is in Atlanta, Tom Johnson and these other CEOs, but so many businesses are beginning to see that if they provide parity, they have a happy, healthier workplace, and the productivity goes up. And so I think some businesses, not all of them by a long shot, so many are not, but I think it's beginning to happen. I think there's a new awareness of the necessity to help people with mental illnesses.
And you've indicated that this concern for cost is really a false concern for cost.
Well, that's the first argument, is it's going to break the bank. But we have evidence from all the studies that that doesn't happen, that the cost is very minimal. And as I said before, over a period of time, overall health costs for a company actually come down. And I think the main reason is because people go to primary care doctors, and when mental health services are available to them through insurance, and they access the professional mental health person, then and get treatment, then they have so many fewer trips to doctors, to the primary care doctor. Some primary care doctors understand about and recognize mental illnesses, but they are very few.
Thank you very much, Mr. Carter.
Gentleman yields back his time. It's a pleasure to turn to our Dr. Bustani for 5 minutes.
Thank you, Mr. Chairman. I'd like to thank you for holding this hearing, and I want to thank all the witnesses for your very excellent testimony. To Ms. Smith, I want to say I have a lot of empathy for your situation, and I applaud your courage for being here today. My daughter, who's 22 years old, would not be alive today if we didn't go the extra mile as a family to seek out care for her depression several states away, because I could not find adequate care in my hometown. And I practiced medicine in my hometown for 15 years as a cardiovascular surgeon, and had pretty good access to just about any health care in a town of 120,000. So the parity issue, it goes way beyond just simply the insurance fix that we're looking at in this bill or even the Senate bill. And I think Jim's nodding his head. He recognizes that just as well, that just doing this is only going to be a real scratch on the surface of the problem, because there's so many other things that affect access to health care. Some have been alluded to today. I worry that this whole thing's going to degenerate into the usual fight over the ERISA preemption. And that's, it'd be a shame if we don't get anything all the way through the legislative process and onto the president's desk if that were to be the block again. And I have a quick question. I guess I'll start with Mr. Troutwine. Do the self-insured groups typically have better mental health coverage than other insured groups?
I think particularly larger employers were first, as the ethic changed from treatment to prevention and management of chronic conditions, I think the better coverage followed that ethic.
Because I worry that if we dismantle the ERISA preemption and take down what are good plans, then we're actually doing more damage in the long run, and I guess that's a concern I have. I know the Senate has worked very hard to strike that balance, looking at the reality of how do you get everybody together to move something forward, and I guess that's one concern I have about moving this House bill forward, and hopefully we can continue to have serious dialogue as we go forward on it. Mr. Dilweg, when you were testifying, you mentioned that if the Senate bill is enacted, consumers would lose existing state-based coverage guarantees. But under the bill, wouldn't the states regulating insurance remain undisturbed unless they clearly violate a federal standard?
I think how we look at the Senate bill is, I mean, obviously it deals with the ERISA side, and in Wisconsin about 40% of my population is under self-insured plans. So we welcome this issue coming to those self-insured plans. But I also see that we would need to implement new legislation. We have a legislative intent on a very low mandate that's been there for 30 years of $7,000 capped on just an overall cost, not specific to benefits. So it would be beholden to our legislature to enact parity, and for the past 30 years we've been unable to enact parity, so then I would look at about a third of my population potentially losing their current $7,000 coverage, and this is also reflected by the state of California as well. They share, although they have full parity, not a lower coverage that we do, they share our concerns as well on this.
I mean, isn't it true that some states have weaker requirements than clearly, and I guess if we were to enact the Senate bill, it might have a positive impact in some 25 states with weaker or existing requirements.
Well, I also worry that it's easier for employer groups to move state by state and knock down parity laws. So you could have really an all or nothing situation in some of these areas. And that's a concern of mine, concern in Wisconsin. So, the House bill may not be as convenient or as the Senate bill, but I am concerned about my consumers, and I'm not alone in that, in sharing that.
Mr. Breyfogle, would you like to comment on that?
Yeah, there's a specific provision in the Senate bill that basically says if a state law has a parity component and a mandate component, that the Senate bill only preempts the parity component, leaving the mandate component in place. What that would do in a Wisconsin case is basically raise the bar, eliminate the $7,000 limit that's permissible in Wisconsin, and raise the bar and allow full parity on benefits and some existence of a mandate. There's a sort of tricky legal question, which is, because of that, then a state court might look at if this provision is severed, is the rest of the Wisconsin law preempted? I think the answer is probably not, but the important point is it's the same legal issue even under the House bill, because the House bill says that it would preempt any state law that preempts the application of the new federal standard. So the problem in Wisconsin is under the House bill, because the parity rule in Wisconsin, there is no parity, so you would have a situation where a $7,000 limit is preempted even under the House bill. It would be jacked up, so you have full parity, and you still have state courts struggling with the question of, given that, would the state of Wisconsin legislature have adopted the original mandate plus parity? So the House bill creates the exact same legal issue for Wisconsin. And any state that has coupled parity with mandates where the parity rule is not a full one or complete one has that same issue. So it's really a specious comparison, Senate to House.
I'm going to just permit Mr. Dilweg to respond, then we're going to go to Ms. McCarthy.
Sure.
Thank you, Mr. Chairman. I think, you're getting into the detail of preemption here, but I think, what I see from my perspective is a lot of experts disagreeing on preemption in the Senate with the Senate bill, and a lot of attorneys much wiser than me getting into that, but I recognize when attorneys disagree that I'm going to be in court for about 5 to 10 years. I look at what's in the House bill and I see the HIPAA model moving forward, and there's pros and cons to that, but that is a working model. Yeah. And so that's...
We certainly don't want to do anything that would disrupt the ERISA preemption litigation industry. The bar that has grown up around interpreting ERISA preemption is a very valued part of our committee. I would go to Ms. McCarthy for 5 minutes.
Thank you, Mr. Chairman, and thank you for holding this hearing. And my colleague, Mr. Amstead, I remember being on the floor at 2 in the morning several years ago when we actually thought we were going to bring the bill up and get it passed. Unfortunately, here we are many, many years later. I thank you for certainly carrying this through because it is an important issue. You know, I think that the majority of us know someone that has gone through mental illness. I can speak for someone in my family who I've watched over 30 years struggle. And I will say that it's only in the last couple of years that finally, bipolar, but finally coming up to a medication that actually worked for him. It's a great time right now for what we've seen in the advancement of medications to help people, and it's like night and day. You know, my brother, who I loved through all those years, to see him happy is probably the most rewarding thing. When you talk about medical management, and you know, I have a concern with that, mainly because my office, and I can't speak for other offices, when we see a lot of these health plans that have medical management, there is a constant fight because they're denied, to the point of where our office has to get involved to get the treatment. And I'm not talking about mental illness, I'm talking about any kind of health care. So I can see I could see this coming down into our office on trying to fight for people for the care that they should have. You know, when I hear about CEOs, we know that CEOs want to have mental parity, many because they train a lot of their employees, and it costs them a couple $100,000, and yet when they fight to have, whether it's depression or anything else, they're having a hard time, even though they're paying the insurance companies to have that treatment. It gets down to be a hassle because the patient or the employee is not going to fight constantly to get the treatment that they need because they'll give up on it. And I've seen this too often. So hopefully, you know, we're going to go down the road and get a bill out that will be good for everybody. But I guess the question that I wanted to ask, and I'll throw this out, on September 11th, we had a national tragedy. Katrina, we had a national tragedy. And certainly with 9/11, I'm still dealing with, when I say the children now, they're all going through post-traumatic syndrome. You can see it through the therapy that they've been getting. We've run out of money. Those groups that came together to take care of the families and now the children, there is no money for them to take care of them. Most of them don't have the kind of insurance where they can get the treatment that they need. So I'm probably leaning more towards the bill, the Ramstead bill, only because people will have the access that's there. But I guess my question is, do you think that the mental health parity regulation would have helped the nation and my constituents recover from this disaster more quickly? And what do you view as the benefits for having this legislation in place in the event of future national tragedies and disasters like that, those that we witnessed on 9/11? Mr. Wellstone, if you have an answer for that, I'd love to hear your input.
Yeah, would you be able to repeat that for me again? I'm sorry.
Talk about 9/11. I mean.
Yeah, no, I've got your question. I think if we had had a mental health parity bill, it would have helped. Absolutely, because people would have been able to access much more treatment. So the answer is yes, I think it would have.
Because I dealt with certainly we had a very large impact in Nassau County where I live, but I think the nation as a whole, you know, suffered a great deal of anxiety and depression.
I think you're absolutely right. I mean, and I think it's just the right thing to do. I think it's the right thing to do to allow everybody to have access to decent treatment and care that's going to help them. And then when we hear these costs, I mean, it seems like it's very, very iffy if there's even costs at all. And then when you start to look at the, lost productivity, lost days at work, and all that stuff, it sounds to me that we could not only provide fairness to everybody, but also save money. So.
Well, my background was a nurse before I came here, and I have to say it's been a very tough argument over these years that preventative care or continuous chronic care for anything actually saves money in the end. But hopefully one day we'll win all those battles.
Thank you. The gentlelady yields back her time. We go to Mr. Loebsack for 5 minutes.
Thank you, Mr. Chairman. I want to thank you, Mr. Ramsey, as I did Patrick Kennedy, for coming in and testifying. I'm a new member here and getting to know folks, and only recently I learned of your involvement in this, so I want to thank you very much. I mentioned already that my mother suffered from mental illness when I was growing up, and I dare say that, or at least I would guess, that maybe everybody in this room has been touched by mental illness in one form or another, and if not mental illness, then some kind of addiction. So I just think this is such an important hearing that we're having today, and I didn't plan to come back this early, but I did intentionally so I could be a part of this. So I appreciate the testimony from everyone. I want to make one comment. Mrs. Carter, I've thought about these issues a lot in the past, in part from a personal standpoint, but I never really made the connection between lack of insurance parity and stigma. I mean, I've grown up, I'm 54 years old, I've thought about the stigma aspect a lot as I've grown up, but I never thought about it in terms of lack of insurance parity. Can you just comment a little bit more on that connection?
I really believe that when insurance covers an illness, that it makes it all right to have. I really believe that. Mm-hmm. I have seen that with other illnesses, not mental illnesses, but cancer, for instance. I remember when nobody spoke about cancer and nobody would mention the word, and the stigma was terrible. And when you, Kay Jamison, are you familiar with Kay Jamison?
No, I'm not.
She says that when you find a cure for a disease, the stigma goes away. Mm-hmm. Well, there's cancer treatment now, and there may be a cure for some of them, but not for all. And I think we're approaching that with mental health. We have so much better treatments today, and I think that if insurance covers it, for instance, in some of the companies that we've been watching for years, when mental health coverage was available through the insurance, through the company, it took a while for people to access it. They didn't. The stigma was still there. But then after a while, one would go, and then another one would go, and then pretty soon it just became the thing to do to access this coverage. And so I think that parity will not only help people who cannot pay, that people who suffer because they cannot pay for help, but it will also lift the stigma.
Thank you. Also, I guess when I listen to folks who are concerned about the cost of coverage from an employer standpoint, I get very frustrated, obviously. I understand the concerns, the costs and all the rest, but it also sort of makes me think about just sort of the 47 million Americans who are without health insurance, period, let alone extending it to mental health issues. And I have one question for Ms. Smith, because I'm not sure you've been asked the question yet, but I'm a new member of Congress, and so when I come to hearings or prior to the hearings, I have a very steep learning curve on so many issues. And I can only imagine what is going through your mind as you're listening to all this today. But I do want to ask you, what are your impressions of what you've heard today? Because you have a wonderful, compelling story that you told us. But what do you think about this debate today?
I think that we're right at the dawn of a new age in terms of mental health, and I really agree with Mrs. Carter that I believe that the stigma is lifting, and that the treatments are much improved over years in the past, where they were actually barbaric in some cases. And this particular hearing today really fills me with hope, because it just, like so many people have said, it's the right thing to do. And to hear that over and over again from all these people is really thrilling.
Thank you. Thanks to all of you, and thank you, Mr. Chair.
Could I say one other thing? I didn't mean we're approaching the time when stigma is gone.
I understand.
I mean we were approaching the time when we have good treatments and know a lot more about the brain and how to deal with mental illnesses.
Thanks for all your efforts, too.
Before we go to Mr. Hare, Mrs. Carter, it's my understanding that your later flight's been canceled and you need to depart by 5 o'clock. If you need to leave now, that's fine. But we have one more question over Mr. Hare, so we'll be finished about 4:55. It's entirely up to you.
I think if I have to leave by 5, they tell me.
Very well.
So.
Mr. Hare, you're on for 5 minutes.
I promise you, Mrs. Carter, I'll go fast. I know what it's like. I had a 5-hour flight, too, from Illinois back, and I want to thank you all for coming. I, too, like my friend Dave Loebsack, I'm a new member, but if just as a personal side, if I could, Mr. Wellstone, I had the honor of meeting your dad twice, and I have to tell you that from my perspective, I have never met a better public servant than your father. He was a tremendous man, and I thank you for picking up that torch and moving it. It seems to me, as we're talking about this debate today, and Mrs. Smith said she was glad to hear this, and I apologize for being late on the testimony, Mr. Wellstone, but one thing you said that was incredibly compelling to me is that every 16 minutes, a child or adult takes their lives because of the depression and the pain of depression and untreated and other mental illnesses associated with it. I think the clock is ticking pretty fast here. And so I commend you, Mr. Chairman, for having the hearing. And I want you to know that from this freshman's perspective, H.R. 1424, we need to move this thing very, very quickly. And I'm honored, Mr. Ramsad, to be a co-sponsor of the bill, because I think it's incredibly important. And so I just want to thank you all for that. I just have 2 quick questions, and one for you, Mrs. Carter, and I know you have to leave. You, from your perspective, could you, if we don't do much, or could you go into a little bit of detail if Congress doesn't act on this Parity Act in a meaningful period of time here, what, from your perspective, what it's going to have regarding mental health care treatment, and why it's so necessary that we get this done quickly and correctly?
I think it will be a tragedy if this bill is not passed now. We've had 3 reports. I named them before: the Surgeon General's report, the President Bush's New Freedom Commission report, and they all confirm that the mental health system in this country is in a shambles, and that there's no way to repair it. We have to start over. There's no way to start over and do anything now. I mean, it takes a long time. And there's this great opportunity now to pass parity and get help for people who suffer. People are suffering in our country, and I just get very distressed about it, because it seems like we don't provide help for them, and we don't even have a guilty conscience about it. I'm just so hopeful that parity is going to pass. It will mean so much to our country.
I believe, Mrs. Carter, in my heart of hearts, it is going to pass, and I can tell and I want to thank you for everything you've done on this, and one way or another, as a new kid on the block here, but we'll get her done, and I think it's incredibly important. Mr. Breyfogle, you mentioned that the Senate mental health parity legislation is better than the House bill because it doesn't mandate coverage of all illnesses listed under the DSM-IV. But in Mrs. Carter's experience working with behavioral diseases, she says that all mental illness are potentially devastating. So therefore, covering all of them is critical, it would seem to me. And I guess we need to treat all illnesses defined in DSM-IV in order to eliminate the stigma, and we've heard about that, surrounding the mental illness, which prevents people from seeking long-term treatment and costs more in the long run. I was wondering if you could maybe just respond to that.
I think the point isn't to pick out anything in the DSM-IV that we don't think should be covered or we don't think is appropriate. I think from an employer's perspective, being able to design the terms of your health plan is critical in terms of how you allocate a scarce set of resources to a covered group of people. And so it's a basic tenet. There is no manual that's mandated for traditional inpatient medical benefits that's mandated under law that you have to cover every particular thing. It's sort of a critical point that employers have, which is that they need the flexibility to design their health plans to target coverage in a way that they think is most effective for their particular workforce. It's not that there's anything in the DSM-IV that employers would point to and say this is unworthy. Not every employer can afford the most expensive health plan. Some industries are much more competitive than others. Some employers are just struggling to have a health plan. And so a mandate that requires really unprecedented and further than parity, because it says mental health, the statute is going to define everything that's covered, whereas for non-mental health, the statute's silent. That's really not parity in our view.
Mm-hmm. Well, I think, just to conclude, Mr. Chairman, I think it'll be a wonderful day when we pass this legislation for people who have mental illness and their families, because it isn't just the person with the mental illness that's affected, the entire family is. And if not now, when? And if not us, who? So I yield back. Thank you, Mr. Chairman.
I thank the gentleman for yielding. I want to thank each of the witnesses for their efforts and their testimony today. I think you've given the committee an excellent record with which to work as we go forward. Mr. Klein, did you have any concluding remarks? I did want to say to Mrs. Carter again how very, very honored we are to have you with us. And just as a personal aside, I grew up in a town called Belmar, New Jersey. And in 1976, when then Governor Carter was seeking the presidency, you came to our hometown. I was not present. I was in college at the time. But my father and mother went to see you. I think half the town did. And I will tell you that your picture is in the town hall. Your visit was regarded as one of the great moments in the history of our community. And I think it shows you the esteem with which you're held across the country by people. We thank you very much for your participation here today. Thank you, Mrs. Carter. And we thank the other witnesses, and I would say that I would ask unanimous consent that letters from the Attorney Generals of Maryland, Washington, and Connecticut, and from the National Association of Insurance Commissioners be entered into the record. Without objection, as previously ordered, members will have 14 days to submit additional materials for the hearing record. We thank each of the witnesses for doing a great job today, and we declare the hearing closed.